When I started in this disease over 20 years ago, patient only had melphalan, and there was then a first wave with the initial proteasome inhibitor in IMiDs, and some real gains were made back then. But I think when the immune agents came to play around 2015, the novel immune agents in myeloma, IMiDs are obviously immune agents. We should never forget about that. But when we started to bring these different players together, the IMiDs with the novel immune agents, this is when, not only in myeloma, in cancer in general, these novel immune approaches have suddenly brought to us these long, durable responses. So that's an area of extreme excitement for all of us in myeloma. Maybe we can finally bring all the soldiers on the field together, your classical agents, the proteasome inhibitors and others that will induce immunogenic cell death by killing the myeloma cells, and then this immunogenic cell death, the immune response you expand with these other novel agents coming to the surface. Only a week ago, there was this very exciting approval of a first CAR-T in myeloma, a BCMA-directed CAR-T, ide-cel. There's probably another one, cilta-cel, that may get approved also this year. And we already had Blenrep, belamaf, also a BCMA targeting ADC approved last year. So we have our 2 feet now in the BCMA targeting era. And we are seeing great progress with those. We hope to see even more great progress with those agents. But by looking at these agents, we also discovered that in some patients, we had a great meeting a few weeks ago, the IW Myeloma 21, that there may be an inherent weakness on chromosome 16 on the locus of BCMA. So it may be that in some individuals, this is a locus which is prone to loss, and then you have this inherent liability in some patient, and then when you treat with a BCMA targeting agent, you completely lose it. So you need to think about, all right, what other agents could be brought aside from BCMA? And this is where we have very exciting, I would say, follow-on immune agents going after other types of targets, like GPR5CD, like FCHR5 and others. They are bispecifics in the clinic, and those are beautiful because they're off the shelf. Patients don't have to wait for their modified cells to come back. So I think those will make a huge impact. We talked about the old immune agents, the IMiD. Now you have the follow-ons, the CELMoDs. Ibermamide is making some great progress. So this is of, I would say, great interest. We always looking at next generation dual targeting CAR-T. Another reason why BCMA, CAR-Ts may not be quite durable right now, beside the fact that in some patients you may lose the target, could also be that BCMA is not expressed on the precursor cells of myeloma. So once you exhaust your CAR-Ts, the precursor come back. So if you can have CAR-Ts targeting cell surface molecules also expressed on the precursor cells, then you would take out these cells fueling the recurrence of the disease. So the dual targeting CAR-Ts are also on the horizon. New ways to design cellular therapies, new types of cellular vehicles and K cells, even macrophage in other cancers now have proven great as backbone for CARs. We have these other very cool designs, one called a CAR-BAT, a BAT CAR. I wish I could have come up with that name myself. So yes, I think we are getting in a place where we can have all of our soldiers fighting together to take care of both sides of the cancer. When you talk about cancer, there's always the blueprint of the cancer itself, and then there's the immune system. And we finally have agents that can bring the two together to get to durable responses and remissions in our patients.